Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome to Airway Answers. I'm here with Dr. Lamberg. I'm so happy to have you on. I've been wanting you on for a while now, so I'm glad we got to arrange this. You are a busy guy. You're lecturing all over the place. I think you were booked for weekends and weekends traveling, and you finally settled down a bit, right?
Yes, hopefully.
Hopefully. I'm going to go over your bio, and I have a lot of questions for you. One area of focus I want to talk about is the non-anatomical components to sleep apnea, because I feel like for me personally, that's one of my weaknesses in understanding sleep disordered breathing, where I've read that all cases of obstructive sleep apnea have an anatomical component to them, which makes sense because as human beings, most of us are messed up in terms of our skeletal development just based on being human and epigenetic factors. But the non-anatomical components I feel are really important for us to understand. So we're going to go over that, plus a bunch of other things. But let me do your bio first so everybody knows who you are if they don't already know. Okay. Dr. Steve Lamberg has been practicing all phases of general dentistry in Northport, New York for 40 years with a focus on comprehensive restorative dentistry. Always passionate about sleep and wellness, he became a diplomat of the American Board of Dental Sleep Medicine in 2011 and has served on their board review faculty. He is the inventor of the Lamberg Sleep Well Appliance, LSW, which is an FDA-cleared appliance for the treatment of OSA, and you hold several related patents. He regularly contributes articles to peer-reviewed journals, is on the editorial review board of Dental Sleep Practice, and lectures internationally to help dentists integrate the many aspects of dental sleep medicine into their general dental practice. Dr. Lamberg also launched and serves as a director of PANI, the Pediatric and Adult Airway Network of New York, which has just boomed ever since you started that. Every year, it seems like it's getting more and more amazing in terms of who you have presenting and speaking, and really wonderful. And this Pediatric and Adult Airway Network of New York is there to provide a regional platform where dentists, physicians, orofacial myologists, and other related professionals learn and collaborate on treatment of patients of all ages. Now, the next conference, when is that, Dr. Lamberg?
May 7th and 8th.
Okay, of 2026. So every year there's this conference in New York, and I urge everybody to attend. I've had FOMO. I don't know if I've ever really used that word out loud.
Well, you're coming this year.
So I will be there.
I'm sending a car service to California.
Yes, fly me out there. Yeah, so I'm really excited because every time I feel so jealous when I haven't been able to attend because it looks amazing. So I will be there this year, 2026. So Great. Excited to attend. Additionally, Dr. Lamberg serves as a scientific advisor for Airway at the 𝐃𝐈𝐒𝐂𝐋𝐀 Center in Seattle and has created a course there focusing on practicing dentistry on airway compromised patients. Dr. Lamberg also created and teaches a curriculum for Nearman Dental Sleep Medicine mini residency. And also, you have created a medical screening questionnaire called the Lamberg Questionnaire. Then you published a book in 2020. It's called Treat the Cause, Treat the Airway, which correlates many common medical conditions to airway and sleep. And that's available on Amazon. It's all over the place. In fact, Dr. Lamberg, I feel like I first heard about you. I don't remember how many years ago this was, but I printed off, it might have been before you published this book. There was 50 pages or something incredible that you had created that listed all the different body parts and all of the health related impacts of sleep disordered breathing on each system of the body. Mm-hmm. And I printed this out, stapled it together. I don't even remember where I found it, like online. I stapled it together, and on a plane flight somewhere, probably to a sleep conference, read through and highlighted this. Yeah. And I was like, this is unbelievable. And it's like my little Bible. I have this. I should have brought it with me right now. I could not believe how having an airway issue and a sleep problem impacts every single part of the body, or it has the potential to. I mean, nearly all diseases almost could be related to sleep disordered breathing.
Yeah. Non-communicable diseases.
Non-communicable. It's insane. And the fact that a lot of physicians aren't really aware of that, I think after reading that, it led me to have my dad talk to his cardiologist.
Mm,
Never asked about sleep or airway, yet
yeah.
he had a
Wow.
stent in. And, it's like a lot of physicians aren't aware or asking about that component, sleep and breathing and
Yeah.
snoring. So I know
Yes.
your book goes over all of that, and it's a really important book and really important information for all practicing physicians, dentists, myofunctional therapists, everybody in this field. And then you also introduce the Lamberg protocol, which outlines the workflow from screening to diagnosis to data collection to treatment to follow up. So I want to talk about all those aspects. But before we get started, thank you so much. I know you're busy, so thank you for spending time
Oh,
teaching
thank
us.
you for having me.
Just kind of backing up a little bit, because I'm a speech therapist, so I'm not a dentist, dental hygienist. I
Right.
always want to understand how people got started in their field. So, how you decided to become a dentist, but also restorative dentistry. How does one specialize in being a restorative dentist? Is there a different curriculum? How does that happen?
Oh, I think dentistry is all restorative. I mean, that's where it starts. You go to dental school and you learn how to fix broken things. And that's pretty much what they teach in dental school. It's broken and you fix it. And I call that dentistry 2.0, just fixing stuff. And then eventually you start wondering, why did this happen in the first place? And that's dentistry 3.0. And then if you can pick up risk factors for an airway problem, you can prevent the dental problems. All the dental problems are basically all related to an airway compensation. They show up as erosions on teeth, attrition on teeth, periodontal problems, narrow arches, the growth and development issues. And these are all compensations for the airway. So there's never a time you pick up a handpiece to do something that's not related to the compensation of the airway problem, absent a car accident or sporting accident, an avulsion of a tooth. That can happen. But other than that, that's rare. Most of the stuff that we do, 95% of what we do is from compensation to the body wants to compensate for what the airway problem is to survive. So it does what it has to do, and it takes the teeth out because they're not as important as the air.
Wow. So nearly all dental problems are related to airway compensations.
That's a lecture. I have an hour lecture, and I go specialty by specialty in dentistry. So we can talk about that in the future, but I brought something else today.
Yes. Well, I'm excited too, because you are going to share some slides, but that's really profound statement. And do you think all restorative dentists are aware of that?
No.
Can you talk about that? Because I've had patients who have had, I had one female patient who had about $80,000 worth of restorative dental treatment until she finally got referred for her bruxism, not realizing there was airway compromise prior to that. So how did you become aware of this dental sleep medicine aspect to your practice? Had you always thought a lot?
No. I had two
No.
patients. No. I had two patients that were friends, and they had problems with airway. They were snoring, and they were keeping their families up, and they asked me to treat them with an appliance. So this goes back to 2003, so over 20 years ago. And so I made the Clearway appliances. I didn't know too much about snoring. I did not know what an apnea or hypopnea was, or RERA. I didn't know anything about dental sleep medicine. I didn't know snoring was related to an airway problem. I didn't know anything. It's cosmetic. That's all I thought. And so I called the laboratory, Great Lakes Orthodontics. I knew they advertised making appliances for snoring. And I said, give me the best ones. These are friends of mine. And they were very expensive. And all it was a mandibular advancement device with a high rack screw. It held the jaws in one position, and it was very uncomfortable. And the high rack screw was right where the tongue should be. It took up all the tongue space in between the arches. So naturally, they both came to me 1 week later, and they said, they can't wear this. It feels like ski boots in my mouth. And I just said, that's it. I gave them their money back, and I decided I'm not going to do this. It's a very bad business model to give the patient the money back and pay the laboratory because they made the appliance. You got to pay the lab technician. So I didn't ever think I was going to make another appliance until about a month later. I'll just call him Dr. Allen, came in. I can't say his last name, but he came in my office. He's another friend of the family. And he said, I snore. I keep my family up at night. I said, I don't make those appliances. Well, Harry told me you did. And he told me you made him one. So I assumed that you make them. And I said, look, this is what happened. And that's why I'm not making you one, because it just not comfortable. You're not going to like it. I don't know if it's going to work. And and I'm not paying for these lab bills. So he said to me, look, let's work it out like this. You can make me all different appliances and I'll pay the lab bills. So now I'm thinking I got a good deal. This
That's
is
the
such a deal.
patience I have.
Such a deal, right? I'm not going to lose money here. I'm not going to make money, but I'm not going to lose money. I'm helping a friend. So I started making him one appliance, another appliance, another appliance. He hated all of them, 6 appliances. He paid the bills. And over the process of that, I started to understand what was going on a little bit with moving the jaw forward. And if one appliance would have one feature that he liked, I would kind of register that. But the sum of the whole experience was, you don't like these appliances and forget about it. And it was a Sunday, and he said, can you do me a favor? I said, no. I said, I'm done with you. He said, can you invent me something? And he had a pair on him to ask me after all that work for nothing. He wanted me to invent him something. So I closed the door. See you later, Alan. And then I went home. That night I was thinking about it, and I was thinking about, what if I just made like kind of like an NTI, a deprogrammer, and that pushed out the lower jaw. And maybe something simple, not like all the stuff that was already on the market. And so that began my story. I started with an NTI with 2 teeth, then to 4 and 6 teeth, so they wouldn't put so much pressure on the incisors. And then he needed a suck down device, a thermoplastic suck down for the lower, to prevent the lower teeth from being pushed out, the lower incisors, because that would be a problem. And that's how the appliance pretty much was started. I happened to have a patient who was a designer, an engineer designer, and I showed him all my paper napkins with drawings on it, how I wanted to design it. And that's really it. There's more to it, but that's enough for now.
And that's kind of the beginning of the Lamberg suit.
That's the beginning of the Lamberg appliance. Eventually, I was drawing pictures for a patent, and I was thinking, oh boy, I wish there was another way. I wouldn't just have to hang this just on the teeth. And I thought of another deprogrammer called the 𝐃𝐈𝐒𝐂𝐋𝐀 deprogrammer, named after John 𝐃𝐈𝐒. Just an anterior point stop. That's all it is, to separate the teeth and deprogram the muscles to prevent the back teeth from being in occlusion. Anterior point stop. It's a deprogrammer, just like the NTI. I called John the next week and I said, can I use the platform of the 𝐃𝐈𝐒𝐂𝐋𝐀 appliance and then add, for lack of a better terminology, a stalactite hanging down to push the lower jaw out?
Mm-hmm.
And he said, sure, you can use it. There's no intellectual property. They've been using anterior point stops in Europe for a long time. So I said, fine, I'm happy to do that. And then when I drew it, I knew that was where this was going, because it's very easily adjusted. The tightness of it, I put some Adams clasps on it. It's a very simple appliance. It doesn't look scary if your kids see it. And they all work the same. The literature supports that they all work.
The lower jaw, so it doesn't fall back. Is it from the piece?
Yes, there's a piece that comes down, that hangs down, and it pushes on a member on the lower. So it actually pushes the lower jaw. I have a picture of it, which I can show in the slides later.
And so the jaws aren't held together, but just that piece prevents the falling back.
Yeah. Now, there was a time when we had rubber bands connecting them a little bit, but that's not sustainable. Nobody wants to go looking in front of the mirror and take out rubber bands every night and do that. It's too much work. We know it's not going to happen. So I just made this. It's about 13 millimeters long. So they can open and close. Okay. Almost 2 fingers. They can open and close. And the thing, that part, that protrusive element that hangs down, we call it the PE, or the protrusive element. That is not vertical up and down. It has a curvature, and the curvature is on the arc of, it's about 100 millimeters from the hinge axis of the condyles to the lower incisors. So there's an arc. So I copied that arc into the geometry of the front surface of the protrusive element, so they can open and close those millimeters, and they don't retrude or protrude, which would change the position of the mandible. So I call that smart trusion. It's trademarked also, and that just means they have a variable amount of vertical changes without changing any of the protrusion.
So kind of the rotation allows the
Yes.
rotation versus translation. Okay, that is really interesting, and that's amazing because you had this friend who funded your research, right?
It was random. It was totally random.
What an opportunity, right? To have that and to have that push or that pressure after being let down by like, this doesn't work. This is a waste of time and money. And this friend came to you and they're like, you need to help me, because our sleep airway patients need help. Most of them are struggling in different ways, whether they're keeping their family members awake from the snoring, they have health issues. And so how neat that you developed this mandibular advancement oral appliance.
But I didn't know what I was doing at all. And then this other Dr. Allen, the problem was he was a physician, Dr. Allen, and he started sending patients to me for this. And no, it's right. So I feel like I didn't know anything that I was doing.
Oh, man.
I never heard apnea or I never heard the words. I wasn't looking to start another part of my practice. So in the JADA, I opened up one day, JADA in June, there was a meeting in Park City, Utah. And I said, I guess I have to go. It's the Academy of Dental Sleep Medicine. What the hell is that?
Who are those people?
Who goes to dental sleep? Who goes to Utah in the summer? And I mean, Salt Lake City and Park City, there's no alcohol, there's no skiing. It wasn't.
No film festival,
no festival. But I went and I walked into the exhibit hall, and there were 750 dentists, and my jaw dropped. And I realized that was my aha moment, because I knew that there was stuff here that was worth studying.
Wow.
And learning.
It's a whole other club of specialists there.
Yeah.
I'm just wondering then, going back to practice after, learning about airway and sleep, and you already had this interest because you're helping an MD friend and you think you're just helping him stop snoring because it's bothering his family members, not realizing you're probably saving his life in various ways.
Mm-hmm.
How did that change your viewpoint on your other current and past restorative dentistry patients?
Well, that I have to be honest with you. It took some years for me to figure that out. I didn't just immediately, I didn't have that aha that every patient, everything I was doing, I didn't know it was all related to everything. I was going to the AADSM. I found a couple of mentors and I went to their offices around the country and I took their courses. And then I just got this desire to become a diplomate. And at the time, it was a young society. And young societies have a very, very high bar for becoming a diplomate. They have an exclusive net, a little group, the inner group, and they want to just keep it all to themselves. And they didn't want anybody else to become members too easily. And so we were given a reading list of 300 articles and a couple of textbooks, and they didn't provide any articles. We had to go online. And 20 some odd years ago, not so easy. Now you can get them, articles, pretty easily.
Yeah.
But then there were some of the articles were in German and a couple in French. I was had to go to Stony Brook University in the archives and download articles. I mean, it was 2-3 months of work just to get the articles, and then 6 months of reading, and then you had to present 20 cases, and the cases were in different categories, and you didn't do it orally. They just gave you this big checklist. And I remember when I finally finished, it took 60 cases before I had 20 that met the criteria for the submission, and which is kind of typical, I guess. And I submitted it. I went to FedEx them this stuff. They're in Chicago, of course. And I'm thinking, God, I'm afraid. What if something happens? So I copied everything, got copied, duplicated, and it actually was 15 pounds of paper. I weighed it. It was ridiculous. It was so much work. Everything had to be overseen by a sleep physician. Nobody really did it like that. Today, it's so easy to become a diplomate. They give it out like a lollipop because they realize they have no gravitas as an academy unless they have a larger number of people that are doing it. And then they created this master program, the master class track, which is different, which you have to go and pay money and take courses from them. So, American Academy of Cosmetic Dentistry did the same stuff. They were really exclusive, and then they became very easy, and then they created the fellowship. So it's a typical life of these academies.
Yeah.
I don't begrudge them that.
No, because I think in general, they want more people to be educated and aware and interested in that aspect, right? It's kind of like myofunctional therapy. When I did my training in 2008, the international exam, the IAOM exam to become certified, felt like pretty exclusive. I wrote a 181-page paper.
Whoa.
Yep. All research. It was a way harder exam than it is now. It was a lot longer, all essay. And then you had to have like 6 hours of someone observing you at patients with different stages of the process. And you had to achieve a certain score by 2 raters on different parts of the exam. And I believe now the exam's multiple choice questions and a little bit easier because they want more people to really be interested. And they want it to be exclusive in terms of you have this special education, but not exclusive where we want to sift people out. We want to bring people in because
you need 5,000 of you or you don't count.
Yeah.
Like you do. You need like 500 of you in every state.
Yeah, exactly. It's such an important thing for people to be aware of.
Right.
So I understand what you're saying about that change in the qualifications or the exclusivity aspect of it. So it sounds like it took you a lot of training to start reviewing your patients differently or to notice that.
Yeah, it did. It took time for me to catch up. I mean, my legs were moving, but I wasn't going forward. I was studying and studying, and I found the articles. Some of them were kind of interesting because it would tell you, hey, if you have a AFib, you have a 65% chance of having OSA, or if you have reflux, you might have a 60% chance of having OSA. And then one article said if you have the reflux, they wanted us to know if you have OSA, it causes everything else. That's what they wanted us to know. But in the literature, it would sometimes flip that around and say, if you have this condition, the odds ratio of you having OSA was X. And I thought that was really interesting because then we could use the medical history as a risk assessment tool. And I was at a subsequent meeting of the Academy of Dental Sleep Medicine. It was 2 or 3 years after that initial meeting. And I got to meet Steve Carstensen, who's the editor of the MedMark publication, which Dental Sleep Practice. And so I had put together an idea. I had 6 categories of medicine, and I had these articles that supported if you have these conditions, you have an increased chance of having obstructive sleep apnea. And I said, can this be like an article, you think? And he looked at it, and he looked at it. I said, this is interesting. He said, yeah. Why don't we do that? Why don't you, give me 3 pages, in an article with your references? And I sent it to him, and I still have the article. And it's funny because it went from 6 categories to 19 categories now. And that became the basis for the Lamberg questionnaire, which then I go to the 𝐃𝐈𝐒𝐂𝐋𝐀 Center a lot. I participate in the courses out there. I showed it to John 𝐃𝐈𝐒𝐂. He asked me to speak about it. And it was really an honor to speak at the 𝐃𝐈𝐒𝐂 Center about it because they're like the best continuing education center, I think, in the world. I don't think too many people would even think of arguing with John 𝐃𝐈𝐒𝐂. The integrity that goes on there, the legacy that he's left there it's hard to compare with anywhere else in the world. And I feel honored because he asked me to speak about Airway stuff, and it was back around 2015. And I had taken a break, and then I went back to the 𝐃𝐈𝐒𝐂 Center, and he said, "Oh, I'm glad you came back. I still have 2 courses or 3 courses, John, to finish your curriculum." I said, "What should I do?" He said, "Well, I think you should finish the curriculum. And by the way, you're speaking on Wednesday night, to the group." And I thought, okay. I had some slides. I threw them together, and I presented. And he liked the questionnaire. That was part of it. And he called me in his office. He said, "I want you to give me an interpretation key, because the questionnaire is going to be part of the risk assessment tool in our advanced courses for treatment planning." we want people to start doing that. Give out that questionnaire because it shows a risk of having that. And having the sleep-related breathing disorders, that's a risk for having dental issues. So it's perfect. But we don't have questionnaires that don't have interpretation keys. So I said, sure, John, whatever. I'll go home and I'll write interpretation key, which I'm thinking 2 or 3 pages. How am I going to do this? But I sat down, and the first night, no. So I called him up the next day, and I said, John, there's good news and bad news. And he said, okay, what's the bad news first? I said, bad news is I'm not doing an interpretation key for you, for your center. He said, okay, what's the good news? I'm doing a book because it's going to require a book. And he said, that's even better. I love it. So instead of, because all the questionnaires have little simple, 2-3 pages, couldn't be done because it's too big a topic. It needed references in each area of medicine, and it needed an explanation. It needed to have what's the odds ratio of having these airway problems, depending on all these medical conditions. There's hundreds of medical conditions.
Yeah, and that's what your book
That's
is.
the book.
And I feel like every physician should read your book and should know about this, about the correlation between sleep airway issues and different medical conditions. Could you name some numbers or some percentages? Like you talked about reflux, AFib. What are some other things correlated with sleep disorder breathing or obstructive sleep apnea and other health conditions?
All the cardiomyopathies, asthma is another one. If you want to do the pulmonary, now I just added another one, which is inflammatory bowel disease, and that includes Crohn's and ulcerative colitis. There's a 2x. In other words, people that have Crohn's and ulcerative colitis have twice the likelihood over the general population of having a sleep-related breathing disorder. And that's just a brand new addition as of last month. And so they just keep coming out.
See, and that's the thing, is sleep disorder breathing is an inflammatory condition.
Yes.
Right? So it makes sense. Autoimmune disorders is going to be a high relationship. So people with Crohn's disease and inflammatory bowel disease have 2 times more likelihood of having sleep-related breathing disorder.
Yeah. Yes.
Do we think all GI doctors are aware of this and are screening for sleep disorder breathing in their patients?
No, it doesn't mean that they have it, but it's just, I'm very careful. This doesn't mean that they have a sleep-related breathing. There's other things. Hereditary things. It could be other inflammatory environmental things that they're dealing with, and there could be psychological stress, which also creates inflammatory milieu. So you kind of just got to walk here and just be humble about this. We just know that's increased risk. So if you have enough risk, if you keep building, checking off a lot of boxes in the questionnaire, that kind of paints a picture. It's just to get people thinking.
Exactly. And when you say sleep-related breathing disorders, a lot of these conditions, it's not just obstructive sleep apnea, or are you thinking it could be upper airway resistance syndrome?
Yeah. So that's a really great topic, and I don't want to completely derail us, but because there's so much general territory to cover today, but this is missed because a lot of times in the literature, I'll give you a simple example, like bruxism. How come some people brux, but they don't have obstructive sleep apnea? So that's been done in certain articles, and then there will be speakers that stand up and say, see, if this person's bruxing and they don't have obstructive sleep apnea, that means that the obstructive sleep apnea is not the cause of the problem because these people don't have it. So I'm like, that's an incomplete thinking, because we do know that just having this bruxing to go on, it requires 3 or 4 minutes before. The literature is pretty clear on this. There's an increased outflow of sympathetics. Now you can get that from other places. You can get that and not have OSA. You can have upper airway resistance, like what you're saying. You can have subcortical arousals. In other words, you can have 1 or 0 cortical arousals, because sometimes the afferents, which are the nervous signals from the baroreceptors and the chemoreceptors, sometimes they go up the ascending pathways to the cortex, but they get derailed and they go to the hypothalamic, the limbic system, and they can cause an arousal also and activate the sympathetics. So there's no cortical arousal, so there can't be any OSA, but it's airway related.
And
It's caused by the airway, but it's not OSA. So to
right.
make the conclusion that because they don't have OSA, it's not airway related is incorrect thinking. It's
And
not complete.
exactly. And I know Dr. Simmons, the sleep medicine doctor, says that bruxism is airway protective. So if the
Yeah.
person was not bruxing, they would have apnea. They're actually
Yeah.
helping prevent the apnea by bruxing to open up the airway.
Sure, it increases salivation, which is slippery, and it does a lot of things.
Yeah. And the
Yeah.
muscle tone brings out lower
Muscle
jaw forward,
tone.
tongue forward. So
Yeah.
this is interesting. And this does get into my question about non-anatomical factors related to OSA.
Right.
So I was looking this up and we'll talk about this, but non-anatomical factors play a crucial role in OSA alongside anatomical predispositions, which we
Sure.
know. But factors include impaired pharyngeal dilator muscle function,
Right.
low respiratory arousal threshold, which is a propensity to awaken from respiratory stimuli, and unstable ventilatory control, so high loop gain. Could
Mhm.
you break those down for us? Could we talk
Sure.
about each of those?
Sure. So the nervous system can get burned out, right? And as a result of having apnea for a while, this is more of an end stage situation where the nervous system has been taxed, has been compromised. And sometimes these arousal thresholds, we don't know what causes someone to have a very low arousal threshold. And having, just to summarize for people that are watching, a low arousal threshold, think of like a poodle that's, you go boo and they jump. That they have a very low arousal threshold. A little perturbation in the airway, small amount of pressure changes in the airway can affect the pressure sensors that are in the airway, and that can cause a fragmentation of sleep, causes arousal, and can mess up your sleep cycles.
Would that be more of someone with upper airway resistance?
Yes, that would be like an explanation of upper airway resistance.
Now, wait, I have to pause here because my brain goes wild. I'm just wondering, could a history of upper airway resistance syndrome cause a low arousal threshold because the body is in a high sympathetic state versus
Yeah.
low arousal threshold causing the UARS? Does that make sense? Like your body.
Yes, but we don't.
Airway problems.
It's probably bidirectional. It's hard to tease all this out. I think that if they're going to have these physiologic non-anatomic problems, which we should tell the audience, about a third of the people have a very high loop gain, or a third of the people have very low arousal threshold, which is a problem, and a third of the people have difficulties with muscle recruitment. And these could be from the receptors being burned out or overly sensitized, and it could be from a lot of things. It could be from the changes in the pH, the ventilatory instability with loop gain changes the pH a lot. And we know what happens when carbon dioxide, when you hyperventilate, like in a loop gain situation, you blow off the carbon dioxide, we know all the smooth muscles start to contract and try to hold it in. So there's easily an hour that I'd love to talk about, but I don't want to spend the whole conversation with you on that. But so those are three very important things. And keep in mind that overarching loop gain and arousal threshold and muscle recruitment, a really important factor is what is the critical closing pressure? And okay, so what does that mean? Critical closing pressure, P-crit is what they call it, and people lecture about it, and the audience, if you look at their eyes, they just kind of go glossy, and they don't really understand what's going on. So I can break it down a little bit. Right now, the two of us that are here speaking to you, we're at 0 atmospheres of pressure, right? And we would like the soft part, the collapsible part of the airway, which is between the nose, non-collapsible, and the trachea, non-collapsible. The pharynx is in there, okay? The pharynx is the collapsible segment of the tube. And the interesting thing is we want that to withstand a negative pressure. We don't want an apnea. We don't want a hypopnea. We don't want all this fragmented sleep. We want about -10. Now, we've all had patients that sat in your dental chair and you just put them back a little bit, and the gravity in the tongue goes back and the airway gets a little bit smaller and they start snoring. We've all seen that. It's crazy, right? Those are your sleep apnea patients for sure, 100%, because their peak rate or the collapse is starting to happen at normal atmospheric pressure. At night, when you're lying down and you're exhaling and inhaling, your pressures are going up and down in the pharynx and the collapsible section of the tube. And we really want you to withstand -10. Now, if you have OSA, you're going to have maybe -4, -6, -7, -8. You're going to start collapsing at like -6 or -7 atmospheres of pressure. So that means that you can't go to -10. You're already collapsed.
Mm-hmm.
So our goal as clinicians is to help the patients have an airway that doesn't collapse until -10, negative -10 atmospheres of pressure. So that's interesting, because if we look at treating people, medicine today is really screwed up because they just treat on the severity. Oh, if you have severe, we're going to give you CPAP. If you have mild to moderate, we're going to give you an oral appliance. Maybe we'll use myofunctional therapy. Maybe we'll give sleep hygiene suggestions. Well, the bottom line is you can't use monotherapy anymore because we know too much. We know that with an oral appliance, we can change the critical closing pressure by maybe 5 or 6 centimeters atmospheres of pressure. So if you take that person, for instance, that you put back in your chair and they started snoring at 0 atmosphere of pressure, and you make them an oral appliance, what can you expect? What's a reasonable expectation? Are you going to solve that problem for that person? Probably not. You're going to get them maybe to collapse at let's be optimistic, -6. Now, we still know that the pressures with inhaling and exhaling, end expiration especially, the pressures drop to about -10. So you get 6 centimeters, 6 atmospheres of pressure difference, and it's actually called 6 centimeters of water. All right, that's what the score is. So to get from 6 to 10, you need 4 more. So you can have them side sleep if they weren't sleeping on their side, and you might get 2 more centimeters of water. All right, and then you have to get 2 more. Well, maybe they could lose some weight, because if they lose 10% of their weight, they're going to have a 30% decrease in their apnea-hypopnea index. So that's going to add something. If you give them some medication, maybe supplemental oxygen for loop gain or arousal threshold, you can get a little bit more steady ventilatory effect on that, and that will change maybe 2 or 3 more centimeters of water. So if you add the position of sleep and an oral appliance, you could do surgical stuff. You can do an expansion. You might get 4 or 5 centimeters of water difference. Okay, so the whole idea is to add up to -10.
Mm-hmm.
And when you get to -10, that person is not going to have an airway problem. Now, what's interesting is they give people CPAPs, and the CPAP can be adjusted, or they can be auto CPAPs. And one of the things we ask in our questionnaire is, if you had CPAP, was the pressure over 10 centimeters of water?
Mm-hmm.
If they have to blow that much, that means they were like a 0 and they're blowing 10 centimeters, because if it's over that, like if they're blowing 12 or 13 or 14, okay, they don't have any apnea, but guess what? They're not going to be able to wear that. That's going to be very, very difficult for them to withstand. They might fill up with air in their stomach, aerophagia. There's plenty of other problems that can arise, and it's just not comfortable to have that much pressure being blown in your airway. It will stop the apneas and hypopneas, but it's not a sustainable solution. So it's a better solution to use all these different things, and we're going to go over that. That's what my slides for today. 15 minutes of just a quickie show of how we can collect some data to find out where are the choke points in that, the kinks in that hose, in that collapsible segment.
Okay.
And keep in mind, the take home on all this stuff with loop gain and arousal threshold and muscle recruitment is, what is the critical closing pressure, and how can we move the patient to -10? Okay. If they can withstand -10 centimeters of water, then they're not going to have the airway problem. And that requires collecting the data and finding out how do we get there, which therapies are going to do that.
And so is the 𝐃𝐈𝐒𝐂𝐋𝐀 determined by the craniofacial features, the structure, the anatomy of the airway?
The 𝐃𝐈𝐒𝐿's caused by everything.
So it's
By
all of those factors.
the
Okay.
totality of everything. Yes, the answer is yes, because the craniofacial structures are going to determine how big the hose is.
Right.
Right. So, and keep in mind that if you have a hose that is like 2 millimeters smaller in the radius, we know the laws of physics and fluid dynamics, it's to the fourth power, the resistance. And so it's going to be cutting down the flow of the air, and the resistance is increasing. And, that's just going to cause more collapse to the power of 4. So just a little bit of change in the diameter or the radius of the airway tube is going to increase the collapsibility dramatically.
And also think of it as the opposite, right? A little bit of increase in the diameter of the tube will decrease airflow resistance substantially. Sure. So addressing the nasal component is a really important aspect. Palatal expansion, reducing airflow resistance. So kind of the point is, anatomy or structure is incredibly important in the 𝐃𝐈𝐒𝐿, but it's not the only factor, because you can have a really large hose or large airway, but you can also have a high collapsibility if you have low muscle tone or open mouth breathing, right? If you have
flabby, you got a flabby pharynx.
A flabby
pharynx.
But you could also have smaller airway, but if you have good muscle tone, patent airway, you might not have apnea. So it's a whole combination of factors when we're looking at our patients with airway issues. And it's not a monotherapy because of that.
Smorgasbord. You got to pick what you want on your plate, and your goal is to get them to -10.
Airway buffet. Okay.
Airway buffet. That's the name of this lecture.
Airway buffet. Sounds tasty. So, really, we have to look at our patients from so many different angles, because when we talked about anatomy and structure, and you talked about arousal threshold, you talked about position. We can change our position, which is going to also impact our breathing, right? Sleeping on your side, angling up more. You talked about weight, right? Our weight is going to impact the airway. Foods we eat, right? Drinking alcohol.
Behavior. How about behavior of mouth breathing? Could be behavior. Yeah. How about look at the chat study and talk about the silliness of what we call evidence. And they take the kids and they find there's not much difference if they did the adenoids and the tonsils and they removed them versus the control group, and they followed up on them. And what they didn't do is they didn't do any behavioral training. They didn't do any myofunctional therapy. They didn't have SLPs going in there and training them to keep their lips together. And you took kids that were mouth breathers, and they might still have been mouth breathers. The methodology kind of ruins their conclusions. It's just not a fair statement.
Yeah, we can't even,
for mouth breathing, that increases the collapsibility 2.5-fold.
Exactly. We can't even talk about monotherapies. And I was at a conference presenting, and we were at the pediatric obstructive sleep apnea all-day presentation the day before. The American Academy of Dental Sleep Medicine, I think it was there. And Dr. Ghazal presented, Dr. Yoon, and we had a full day presentation. The person that presented before me was presenting the summary statement that about 15 reviewers on the board reviewed different treatments or techniques for pediatric sleep apnea and what their consensus was. So it was like a consensus statement.
Yeah.
The consensus was nothing works or nothing is proven, basically, because they viewed everything as a monotherapy.
Yes.
My blood pressure went up. My heart was pounding because I was going next in my presentation, and I had a lot of the same research, but was also followed up with adding myofunctional therapy or adding, but they're like tongue tie release. No, not proven. Tonsil adenoid removal. No, doesn't work. All this consensus. And it doesn't work if you're just treating one aspect of this buffet of airway, the smorgasbord. You have to treat all components. And that's exactly correct. There's many factors. Could you talk a little bit more, though, about the high loop gain, what that means, that unstable ventilatory control? What does that mean?
So, what it means is if they're hyperventilating, During sleep, they're going to blow off the carbon dioxide. And if they blow off the carbon dioxide, that's the driver in the respiratory centers of the brain. That's what causes us to breathe. So the carbon dioxide has a couple of interesting features to it. It will cause the contraction of smooth muscle when you blow off all the carbon dioxide. It also can create a central sleep apneas as well, because if you don't have any carbon dioxide, you might not breathe. And you can't there's nothing like critical closing pressure for that, because as there's no pressure at all, there's no breathing, just the brain says stop breathing. So that's a whole piece on central apnea versus obstructive apnea. But the other thing that happens, and there's a relationship with there's cycles that happen. So they hyperventilate, blow off the carbon dioxide, and then they start overbreathing again. They're overbreathing, and then they stop breathing. They're overbreathing, and they stop breathing. And think of loop gain as just instability in ventilation.
And why does that occur?
They don't have like normal ventilation. There's a continuous overbreathing and stopping breathing. And that changes. We know that it changes the pH in the blood. So that's another factor. And the pH in the blood is interesting, because carbon dioxide causes acidification in the blood. It combines with water and it forms carbonic acid. And when it does that, for instance, take uric acid, which is in the blood in suspension, comes out of suspension because of the acidity when that drops. Because the blood stays in a very narrow range of pH, but when it gets more acidic, the uric acid forms crystals and lands in the joints, and that's called gout. So people say, oh, I shouldn't eat protein and stuff. But yeah, there's a very high odds ratio that they might have a breathing problem, those people with gout as well. And that has to do with holding your breath, and the carbon dioxide is building up.
Wow. So why would someone have high loop gain? Is it the sleep issue that maybe triggered this pattern of hyperventilation, or is it they're hyperventilating throughout the day? They have poor breathing throughout the day that transfers to the night. And there's probably no answer to this, but I'm wondering, there's a lot of
I don't know what the answer
programs.
It's neurologic, but what causes that, I don't know. I don't think anybody knows exactly what the cause is. It can breathing problems cause that, possibly. They could burn out some of the receptors or make them more sensitive, just for a homeostatic drive of the organism, because we want to maintain our pH, we want to maintain our oxygen levels. So the body does some funny things to stay in homeostasis. So I don't know. I don't know that it's been concluded anywhere what might be definitively the cause of these things, but
there's probably no way.
A third of these patients that we get that have these airway problems have a contributing factor of those three things that you just mentioned.
Okay. And I just wonder, a lot of adults who have sleep apnea, it began in childhood, was undetected, progressively worsened, right?
Yes.
So I just wonder if these issues in early childhood can trigger these neurological components. Like, we know there's increased sympathetic tone when we have sleep-disordered breathing along any spectrum. Could just be airflow resistance, right? That brain arousal, especially in children. So does that high sympathetic tone and brain arousal during sleep now contribute to poor breathing throughout the day? So we're going to have autonomic nervous system dysregulation, high sympathetic tone during the day. We're going to kind of be hyperventilating throughout the day because we're anxious, like how I'm talking right now. My veins are popping out of my neck because I'm not breathing. But does that sort of begin in childhood and then trigger this issue during sleep and daytime breathing issues? My brain starts going down that route of the poor sleep, the airway, the structural component starts triggering all these other neurological impacts. And also there's a lot of breathing retraining programs. What are your thoughts on that? So slowing down our breathing during the day, and how does that impact sleep breathing for patients with high loop gain?
I think it's extremely helpful. I think it's wonderful. People have to slow it down. And so the pressure drops are less when the airflow is slower. We should all be breathing slower. We should be breathing 6 seconds in and 6 seconds out. There should be between 5 and 6 inhalations and exhalations. That's a breath. Inhaling and exhaling, that's 1. There should be approximately 6. But our culture today is more along the lines of 12. And if you look at the yogis or take a yoga class, everybody starts the yoga class with some pranayama breathing, which is a slow breathing. And this is to retrain the breathing and also to balance out the parasympathetics and the sympathetics, the autonomic nervous system. It balances that out, which there's so many inflammatory pathways. I mean, if you look at all these non-communicable diseases, they're a result of chronic inflammation. And the thing that is tied to chronic inflammation is the increased sympathetics. So when you have an airway problem, you're always in some sympathetic overdrive, like what you were saying. It could be airway. You could have lost a parent or a child or have a loved one having problems, or there might be stress at work or on the job or on a webcast. I mean, there could be stressors. I don't know what they are, but that increased sympathetics, if it's for long enough, that causes chronic inflammation.
Yeah, right. So by practicing
Breathing slows things, slow it down.
And do you think that could impact nighttime sleep
Yes.
breathing during the day if you can adjust your breathing?
It will decrease inflammation, period.
Interesting.
Period.
So do you think practicing breathing strategies during the day can affect your breathing while you're sleeping, or just inflammatory?
Yes.
Your unconscious or subconscious. Yeah.
And also it has something to do with the mode of breathing too. Is it going to be more from the diaphragm, hopefully, or is it going to be from up in the chest? And we know that this is more sympathetic up here and more parasympathetic down there. So we know that.
And also, our mouth breathers tend to be accessory breathers as well, and we see that.
Yeah.
This is really interesting. These non-anatomical factors, and it's all related. And when I was looking this up, it says these non-anatomical factors, like we just talked about, and I know you're going to go over more because you're going to do a little presentation, but the impaired pharyngeal dilator muscle function, the respiratory arousal threshold, and the high loop gain can significantly impact the severity and progression of OSA, especially when combined with a physically narrowed upper airway.
Sure.
So many components to address and treat and to understand in our patients.
Yeah, and the problem that we have today is we don't have a way from the PSGs of getting this data, because I can show you another time. I can show you a chart where I put together all the different therapies for all of those non-anatomic features that you just mentioned. And we have treatments for it, but unfortunately, there's no way to get it. And your sleep lab's not going to give you that material. Hopefully, there will be algorithms from some of the home sleep apnea tests in our country soon. I know Knox Pharmaceutical had some. I know Itamar is working on it. They didn't let Knox into our country. The FDA thought that people didn't know enough about these non-anatomic physiologic parameters, so they didn't want people to start treating it just because they had a wearable device that was going to tell us the data. So I'm pretty much trying to be as proactive as possible, but what can we do? We need. I know Enso Data is also working on this. I've been talking with them, and there are some other companies as well. But we're trying to take what we do know, like the way that people are breathing at night. We're trying to record that, the heartbeat and the frequency of their breathing, and the apneas and hypopneas and the RERAs. And there are algorithms, but dentists, I don't want to sit there till midnight, doing the algorithm. I want the software to do it and tell me, is there a risk factor that they have loop gain, a high loop gain, or a low arousal threshold? I want to know that. I don't have time to do all those algorithms on my own.
Okay, so what do you do if a patient has a low arousal threshold? Or
I don't know if they do.
If you find out they do, how do you treat those?
So if their arousal threshold is very low, what we want to do is give them some type of a medication that is a muscle, is a relaxant, and we want something that's but it has to be something that's not going to make the muscles too relaxed.
Mm-hmm.
All right. So it has to be something that will decrease that high. It's like being in a state of hyperarousability, right? So if we can actually depress the arousability feature without being a mild relaxant, it's a hypnotic. That's all it is. It's a hypnotic, but you don't want to give benzos because that has a negative effect on the REM sleep. So if you can find a non-mild relaxant sedative hypnotic, that's what you're looking for, and that will treat the loop gain. That will treat the arousal threshold. And loop gain is the ventilatory instability, and that's triggered. Low oxygen can trigger that. So if you give supplemental oxygen, that's one way to treat that.
Mm-hmm.
And as far as the muscle recruitment, there's certain medications that can help with muscarinic receptors and other receptors. I didn't bring any slides on all of that, but if you want to get together another time, I can speak. We can do like 40 minutes or an hour on just those three features.
Okay.
I'm happy to do that. And there are pharmaceutical medications to address each of those features.
The low arousal threshold, though, wouldn't you want to first treat the anatomical structural component and then see if there's still a low arousal threshold? I'm just picturing I had a patient who was upper airway resistance syndrome, but of course it wasn't showing up on sleep studies. And she had all these spontaneous arousals.
Mm-hmm.
And they said the treatment was a sedative hypnotic. But really, she had UARS, and they did a DICE, and her airway was collapsing so quickly that they actually rushed her into a double jaw surgery before they even finished the orthodontic treatment
You have to
first.
do both. You can't just do the. You have to, because if they truly have an arousal threshold that's very, very low, you definitely want to blunt that, but you don't want to use something that will relax the muscles.
Mhm.
It has to be a sedative hypnotic that doesn't relax the muscles.
Yeah.
That's what you need for that.
Look at maybe that cause of her arousing is because her airway is collapsing because she has a structural issue.
She probably has both. Most of these
Oh,
people all have,
okay.
close to 100% have some anatomical compromise.
Mhm.
And just to say it one more time, a third of these people have a loop gain, high loop gain. A third of them have a low arousal threshold, and a third of them have deficiency in the muscle recruitment.
A third of patients with sleep-related breathing
Each of
disorders
those
have each of those.
that contribute to maybe 95% have the anatomic problem. So you have to treat the anatomic,
Okay.
and you have to treat the
Okay.
physiologic as well.
Tell me if I'm correct in summarizing this, exactly what you said, that nearly all patients with sleep disordered breathing have an anatomical component to it.
Yeah,
Like
yeah.
95 to 100%, right? Where most of them are going to have
They might have a
sleep
minor,
Okay.
it's variable.
Because that's human condition. There's probably going to be underdeveloped airways, underdeveloped jaws. Okay, so most people with sleep disordered breathing are going to have an anatomical component.
Mhm.
And those with sleep disordered breathing, 1/3 of them are going to have the impaired pharyngeal dilator muscle issues. 1/3 are going to have low arousal threshold. 1/3 are going to have high loop gain.
To a variable amount. And, this is stuff that comes out of Danny Eckert's group in Australia, and Scott Sand and Andrew Wellman at Harvard. They've done a lot. Daniel Vina, they have a big group up there. And they talk about this thing pretty much year after year after year since 2016, I think was the first article. And it was first put out by Danny Eckert. And I'll tell you, it pisses me off. They were almost 10 years later, and I've been saying to them, why can't you get together with these companies that make the sleep studies and have the algorithms done by the software? And it's an important thing. You keep saying how important this is and how prevalent it is, but you don't give us the data.
No,
So it's sad.
yeah. I'm just wondering if that's a case where it's like comorbid with these non-anatomical factors, that how much of the time when you treat the anatomical factor is the sleep issue fully resolving? It
I
sounds
don't
like
know that. I don't know that it does resolve. I don't. It might not.
Mhm.
These are a lot
You
of
have
things.
to treat these other aspects also. Is that what you're saying? Like if you
Yeah,
treat
yeah.
so can we talk a little bit about oral appliances? How often are they changing the bite in a patient and affecting the TMJ? So would oral appliances be used for mild to moderate sleep apnea? And what are the impacts of using a mandibular advancement device?
So, if there's a choke point at the velopharynx, behind either at the base of the tongue or the velopharynx with a soft palatus, that's an area where we want to then pull the jaw forward, and we want to open the radius, increase the radius of that. And we know that that's going to enhance the flow, and we're going to have less problems. So that's why we use the oral appliance. So for that particular thing, if the patient has a fairly normal anatomy, craniofacial development, but they might have had a sports injury, or maybe they were a mouth breather at some point, and their nose is restricting everything, and they don't have good flow there, the oral appliance isn't going to help that. The patient still has to use energy to draw the air in, or they're going to change the mode of breathing and breathe from their mouth. So either way, they're going to have increased collapsibility of the airway. So that's why I used to think oral appliances were like the bomb for everybody. And I still like to use them, but I use them now. I'm only expecting between 4 and 6 centimeters of water to change the pressure change for the critical closing pressure. And I'm looking for what else I can do to add up to the total of -10.
I like
So
I like
that's
that way of looking
if
at it.
they take home nothing more than from today, we're looking for like -10 to
Okay.
stabilize the airway.
Yeah.
And your breathing re-education is great too.
Okay. This is really good. So cure versus management. What's the difference? And is it possible to cure sleep apnea, or are we just managing it with oral appliances or CPAP
Yeah,
or
well, these are management tools. Yeah, but can you cure it? If you want to cure it, you have to speak in terms of surgical intervention and changing the anatomy, period. That changes the actual size, the dimensions of the airway, which is going to change the flow, and the pressure is going to get more normalized by making it bigger. And if it's a nasal problem and a MARPE or an MSE or oh, they have non-rapid palatal expansion. It seems like every month there's another acronym for these different ways to split the maxillary suture, and there's so many ways to handle that. So if we do surgical intervention, if we release the tongue, which may be tied and pulling it down, or if they remove tonsils and adenoids, which might be obstructing lymphoid tissue obstruction, the airway, posterior airway space, or if there's fat in the base of the tongue, these are things that can be altered. They might lose 10% of their body fat, and they might drop 30%, and that might cure them. But if you think of an oral appliance as a cure, I think that's misguided. I think it's a stabilization technique. I think same thing with oral, with this CPAP and autopap, all of the positive airway pressure. It's just a way to manage a problem, and it doesn't offer any cure.
which sometimes is all that's needed for for people is we to manage versus depending on the age of the patient and the other conditions. When someone's using an oral appliance, do you usually assume that the bite is going to change?
Yes.
Or okay.
I have patients that the bite hasn't changed.
Okay.
I do,
So
but most of them it changes. And what's really interesting is in looking at this, and I recently, for Dr. Jerry Simmons, he asked me to do a piece on follow-ups and management of problems and after oral appliance therapy. And I hated that topic because, as you know from today, I'm much more about lots of other things than oral appliances. And then he asked me to get really specific. He wants to know the problems with oral appliances. So I really hated him for giving me that topic, but he really wanted me to do it. So I put together the lecture, and I really, lo and behold, I found a lot. I learned a lot because I found out that almost all the time there are going to be some changes, and it's not in the joint. It doesn't cause the TMJ problems. Very safe for TMJ.
Okay.
But there is always going to be a little bit of mesial drift of those lower teeth. There's going to be a proclining or like kind of tipping forward of the lower teeth and a retroclination of the upper teeth. Now, what's interesting is we'll frequently see the bite in the back. The teeth are separated and they can't chew. And we get freaked out. And really what's going on there is the coupling, the coupling in the front. Instead of the teeth like this, if the upper teeth come back and the lower teeth go out, okay, so the overbite is reduced, and that causes a separation of the teeth in the back. So that's pretty much what's going on in that instance. But we get freaked out because in dental school, we want to know this cusp goes in that fossa, and they beat it into us, and it's on our exams and on our boards. But the patients, they couldn't care less. I have patients, I mean, I could put a conroll between posterior teeth. It's rare, but I've seen that, and they have not said a word. But I'll see them 3 or 4 years later, and oh my gosh, I can't believe it. But they get by. And the one thing that patients don't complain about is changes in occlusion. They don't complain about it. So it doesn't mean it doesn't matter. And there are strategies to minimize that, and that's called the early morning positioner. So I think that's another thing that needs to be more utilized by more practitioners is this early morning chewy toy, where they basically they're stretching out the pterygoids, lateral pterygoid muscles a little bit, and so the jaw then goes back a little bit, and it also aligns the teeth a little bit too. So there's a couple of features to the morning positioners.
And does that prevent the malocclusion from occurring?
It decreases it. The literature shows it decreases it. Yeah.
Okay, that's good to know.
We make it for everybody. We didn't used to, but the last 5 years we've been making the morning repositioners for every single patient.
Okay.
The bite changes, they're interesting, and I think dentists should just maybe relax a little bit about it. It's not such a terrible thing to have bite changes. What would be worse is if the patient dies or develops some other problem.
Heart attack.
And there is definitely some level of bite changes in all of the patients, and a lot of times in the premolar areas. Sometimes it's negligible and you can barely see it. But if you start using shim stock or bite paper, occlusal tabs, you will see that there will be the dots are going to change on the teeth, and that's just the nature of the beast.
Is that kind of how the bite should be so they're breathing better? Like, don't they say you kind of adjust it and that's how they can breathe at night, and that's where their jaw should actually be lined up, and then you do restorative dentistry to kind of put them in that position?
So if they have a deep overbite, the answer to your question is yes and no. And the yes part of it is you'll see some bite changes like the next day sometimes. Sometimes when there's a very deep overbite and we have what's called a constricted chewing pattern, and that pattern is such that the lower teeth are sort of trapped, and it distalizes, pushes the lower jaw, the mandible back, and that can put pressure on the joint. And sometimes if you make an appliance for that patient, they'll open up and the joint will feel a lot of relief, and the patient will just not be able to get back there. They won't be, and they'll be edge to edge, and they might have had this big, deep. The patients that are at risk are the very deep overbites and very constricted bite in the anterior region. So those patients, I've seen patients come in within a week, and they can't get all the way back. So those are the patients that we recommend. Why don't we do some aligner therapy and build your teeth there? So that's one category. The other category is people over time. So there's like the super short term, and those are the deep bite patients that were trapped, and now they're free, and they're not going back.
And they don't want to go back.
They shouldn't go back. It will help them immensely to be built forward. And the tongue will come forward. Everything will be much better. So
Okay.
there's two categories there. So that's why you were right for the category 1 with the patients that had the deep overbite and they have an immediate shift. But then I have patients that have been on appliances for 12, 15 years. And so they have some mesial drift. They have some coupling changes in the front, and that's different. Can you build them there? Yes, there's nothing wrong. If they have teeth that need to have crowns, I would reconstruct them in that position. Do they have to have all their teeth hitting? That can be rather invasive. And what's the benefit? If the appliance is working and they're not having medical problems, hey, that's great.
Okay.
You have to weigh each patient's a snowflake, sort of. That's what I look at.
Yeah, that's really great. Didn't know any of that. And as we get into your presentation, I just want to kind of summarize a thought too.
Sure.
We just previously talked about non-anatomical or non-structural components to airway issues, but there's also non-airway components to sleep issues. So we need to kind of think of all these things together, right? So we have structural components to airway issues, which trigger sleep issues.
Okay, anatomic, right?
Non-anatomic components that contribute to airway issues.
Two categories there.
Two categories, but airway. They're causing airway problems.
Right. Let's call one structure. Structure is one. And then we have the non-anatomic, let's call that function. Those are the non-anatomic physiologic ones. And then there's the other one that I call behavior. Behavior is the mode of breathing. Or how about their head posture? There could be habits in behavior. I broke it into two categories, which I'm going to show. One of them is habits and one of them is muscle function. Sometimes they have their vertical growers and they can't get their lips together, the poor things,
Right.
So
and these are all in my categories of airway issues. But there's also non-airway components to sleep issues, like
insomnia.
Exactly. So that's what I want to bring up too. Periodic movement disorder, like issues with low ferritin, insomnia, narcolepsy. So as a practitioner who's working with patients who have a high likelihood of sleep problems, we also need to be aware of the non-airway components to our patients, because there is a high comorbidity with our sleep breathing patients also having other factors like low iron or low vitamin D contributing to poor sleep, or narcolepsy. So I've learned from Dr. Simmons that there's a high correlation between narcolepsy and airway issues. And we might treat the airway and think, if the patient's still tired, that we're not treating the airway correctly and might keep going down that rabbit hole, when there might also be non-airway components to the patient being tired, right? So it's just
to sleepiness, excessive daytime sleepiness,
and poor sleep quality, right?
So orexin and all those other, there's
right. So it just makes your brain just like, wow, there's so much to this.
There's so many rabbit holes in this, and that's, I guess, why some people don't go into it. It's bigger than dentistry. It's crazy. It's every system in the body. It's so complex. And there's so much bidirectional stuff going on too.
Exactly. And it's just so important to be aware of all of these aspects. Would you like to share the presentation you want to do right now? You said you have about 20 minutes to share, and I'd love to see that. So thank you so much, Dr. Lamberg. Right now, you're going to present your Lamberg protocol.
So I'm going to just show the Lamberg appliance first. So the blue part is the protrusive element. And so the little part that sticks up is the maxilla, the upper member. And you get a set of parts, and all the pieces are offset by 0.5 millimeter. So that's how it's adjustable. As you can see here, it hangs down and it pushes the lower teeth and the lower jaw out. But these pieces are all variable. And the way you do the adjustment is very simply, you just take the next one and the next one and the next one, and that's what moves it. That's what moves it forward. And if you look at it from the palate, it's all cut out off the palate. These yellow arrows will show this is where your tongue should be, up there to the cingulum of the upper anterior teeth. So there's plenty of room for the palate, for the tongue on the palate here in the anterior palate. And then, so what is the clinical workflow? So the last hour, I guess, Nicole and I were talking about how do we make decisions, and trying to get the airway collapsibility so that it would withstand -10 centimeters of water Okay. And so the way I thought about this is just let's look at how we can figure out where the problems are and address the problems, because pretty much dentistry has followed medicine and just treated problems. It didn't treat the actual cause of the problems. And that's what all medicine is based on. That's medicine 2.0. Peter Attia wrote a great book on that, and it's called Outlive. So if you're interested, I think it's a fabulous book. It's a New York Times bestseller, and it's a difference between medicine 2.0 and 3.0, and ultimately dentistry is coming on to its own 3.0 now with early intervention. And here's the slide. If you remember nothing else today, this is really what we're recommending. You start with screening for everyone. Every single person, a new patient or an existing patient, should screen. Your hygienist should have the screening tools. We recommend the Lamberg questionnaire, but there are several other methods to do this. The stop bang works very well. It's a validated questionnaire. If you have enough evidence that they have a risk of having a sleep-related breathing disorder, then you implement a letter to your physician or the patient's physician and see if they would like to do a polysomnogram. That's what the PSG is, or a home sleep apnea test. And basically, in New York State, we can't do it. It has to be done by the physician. So the screening is for everyone. And then the people that are high risk will then go be referred back to their physician, and their physician will make a decision on the type of test and how they're going to do a diagnosis. And the diagnosis is, in this case, is just, do they have it and what is the severity? It's not about any causes. And that's usually where the buck stops. But we're taking it now to another level. So they may be positive for OSA or they may be negative for OSA. Those are the only two outcomes that you'll get from these sleep tests, correct? So if they're negative, what do we have to do? Then they might have 4 events per hour. That might be causing all these problems. As Nicole was saying, the UARS patients, these people are sometimes sicker than the OSA patients. So we have to be aware they can cause sympathetic upregulation all night long. And it's the sympathetic upregulation that's the problem. So they're either positive or negative for UARS. If they're positive for UARS, then that goes the same direction as positive for OSA. These are the airway problems here. And you made a good point just before, and you said there are other issues that are non-airway. And what might that be? That might be insomnia. And there are some other ones as well. But, when you make a map or a road map or a workflow map, you can't put every hamburger joint, on the map, because then you wouldn't be able to see the road. So this is kind of just an example of how to think. So here's the next generation of data collection. And if they have an airway issue that's UARS positive or OSA positive, which is obstructive sleep apnea or upper airway resistance, then we go into data collection. Why? Because we don't want to just diagnose like the PSG or the HSAT that they have a problem. We want to diagnose what caused the problem and where are we going to send our arrows? What's our target going to be? And we divided it into structure, function, and behavior. And then there's the plus, which represents some other things in addition to behavior. So what is the structure? The S stands for structure. This would be nasal resistance and obstruction, or it could be soft tissue restrictions or skeletal and dental compensations. The function is what we were talking about with the loop gain and the muscle recruitment and the arousal threshold. That's what the physiologic dysfunction is. That's the F. The B is behavioral issues. And the behavioral issues I categorize into either the way the muscles work, if the muscle, maybe the lips can't close, and that would be for a myofunctional therapist or an SLP. And they may have habits. They might need training and learning habits. They might have, their head might be leaning forward just to help open their airway, but that can be causing other problems. So in addition, there's the plus, and the plus stands for genetic contributions, and then screening for 𝐃𝐈𝐒𝐂𝐋𝐀 and 𝐃𝐈𝐒𝐿, which I can't pronounce really, but what is 𝐃𝐈𝐒𝐂𝐃? So we used to call it sleep disordered breathing plus, and now it's called comorbid insomnia with sleep apnea. So it's a big, hairy acronym. Sorry. There's a lot of acronyms in this field. And I think Nicole knows this just, as well as I do. So let me say it again. Comorbid insomnia with sleep apnea. So if you can have comorbid insomnia with sleep apnea, you can have it also with UARS, upper airway resistance syndrome. Okay. This is a term I just made up. I think eventually someone's got to do something with that because a lot of people have UARS and a lot of people have insomnia that's comorbid. So then from this data collection, next gen data collection, we look at all this data and then we get down to the targeted algorithms. And how does that look? So let's back up and zoom out for a second. And we have these traditional screening questions. And this book will go through it. If you're interested in getting the book, or on my website, you can download this for free, the screening tool, which is called the Lamberg questionnaire. And we look at traditional screening tools. And we did make a reference before about the CPAP pressure. Was the pressure larger than 10.5 centimeters? Yes or no? I want to know, because if it was larger than 10.5, I don't think the literature shows that there's a very low likelihood that just an oral appliance by itself is going to help. So it will need other things. This is just an example of what we're starting to think of. How do we get to that -10, that nice magic number? Then we have cardiology and vascular medicine. Do you have high blood pressure? Have you been diagnosed with coronary artery disease, stroke, heart failure, pacemakers, pulmonary medicine? Yeah, I think I'm not going to go through all of these because it's not the point. The point is just to say that the book will explain in 2 to 3 pages how all these things like erosion and acid reflux or heartburn, how are they related to airway and gastroenterology? And it's strange, but the gastroenterologists, most of them haven't really tuned in to this. And they'll tell you it's a lower esophageal sphincter problem. And, it probably is a lower esophageal sphincter problem. That's part of it. But, my answer to that is, what caused that? Were they born with a lower esophageal sphincter problem? Were those little flaps, those little muscles that are down there, was that always a problem when they were born? Or was the negative pressure in the airway something that kept pulling and pulling? Just like when you see a uvula that's long and hairy and hangs down halfway down their throat. How about the lower esophageal sphincter muscle? So good luck. Good luck. But I have references. You can share that if you're friends with somebody in that field. And here's neurology and endocrinology and the otolaryngology and urology. And I think if you look at the pills that guys take today for erections, this is all because of a lack of nitric oxide. And what happens is, if you're not breathing properly, you need oxygen for nitric oxide. A, and you get less of that if you have a sleep apnea. And B, every time you have an arousal at night or hypoxia at night, you get this sympathetic activation from both of these things. And whenever you have sympathetic activation, the blood vessels in the periphery close. And in order to open them, you need nitric oxide, and that catalyzes the reaction. So if these people are having difficulty getting erections, they're having what's called refractory hypertension. And that the blood vessels aren't opening up. So they need to take something to substitute for the nitric oxide. And that's what this Cialis and the Viagra and all those pills, it's just a matter of the fact that it's not bioavailable because of the decrease in the amount of oxygen that the patients are getting, and also the increased demand because of the number of events causing sympathetic activation, and the blood vessels need to keep opening up. It uses up all the bioavailable nitric oxide. Then dentistry, the grinding, we talked about that, and psychology and rheumatology and dermatology. And, again, this is all, you can get this on my website for free. And the book is 17 something on Amazon in English. It's also now in German, and it's coming out in Italian, and it's also coming out in Polish, which is cool. So here's the data collection. Okay, that was the next thing. Remember the first figure, if they have OSA or if they have upper airway resistance syndrome. Now we want to say, okay, what are we going to do? I don't know. I don't care what their AHI is. I care what's causing the problem. And Nicole and I have been talking for the last hour about structure, function, behavior, which are the habits, and behavior, which is the muscle function. So we broke this down like this because it has to be bite-sized. Otherwise, people won't really appreciate it. It looks complicated, but this is a simplification in a way. And these are all the cut points that are in the literature. They're all the cut points. And all these cut points represent what makes an increased risk of the airway collapsing. So if they have certain problems like tonsils, enlarged uvulas, allergic shiners, these are ones that we're going to refer to the ENT. So you see this color for the otolaryngologist? Well, that's the ENT stuff right there. Or if they have a deviated septum or a septal spur, enlarged swell by, that's off the septum in the nose, or concha bullosa, which that happens sometimes to the turbinates. It's they fill up with air and they become large and they obstruct the nose. Or they might have an enlarged adenoids and or hypertrophy, enlarged turbinates. So anything that's this color gets referred to the otolaryngologist. The yellow is orthodontists and oral surgeons. So here's some cephalometric numbers here, and here's information that we get from the CBCT. And my assistants, they said, we really should divide it, because you go in the room and we collect this data in the clinical room, but then this data we collect from the CBCT room. And then the Ceph data, sometimes we get it off the CBCT, and sometimes the medical radiologist will give it to us. A lot of these companies have AI now, and so they can produce the two-dimensional cephalometric data from the three-dimensional CBCT. So this is the structural stuff. Now, we attack the structural stuff differently because it depends. Now, if they have erosion, excessive tooth wear, TMD, load test, we find out they have a problem there, that's dental. Okay. And on this whole thing goes. Now, if we're going to skip function, because the physiologic things that Nicole was talking about, the p-crit, the loop gain, the dilator muscle, and the arousal threshold, because we don't have the data. We would love it. We do have solutions, but we don't have the way of ferreting out, which patient has those problems. In the world of speech and language pathology, though, and myofunctional therapy, the habits would be mouth breathing, forward head posture, chest breathing, low tongue posture, and the behavior would be muscle function, if this overactive muscles, and tongue thrust, lip incompetence, and on it goes. When they try to swallow, when you see they employ all the muscles of their whole face, there's a problem there. So let's go on to the next slide. So this is the data collection. Now, my staff does this, and in the course that we teach the assistants they get 95% of this data. And so it takes them an hour to collect this data, but then we can target what the solutions are. You can't target solutions unless you know where the problems are. And these are the people that we refer to. And I will come into the room after the first hour, because I want to do the construction bite and know where to start the oral appliance if we're going to do that, which usually we make that anyway, but we tell the patient we have all these other things that we have to work on. But my dental assistants usually will tell them, they'll check all these boxes and say, okay, this is where the patient's going. Again, here's the data. We collect it. It's divided into structure, function, and behavior, N plus. And then we develop from that 7 targets. And each one of these targets is a special target, because it will require us to employ or refer to a certain type of physician or dentist. So there are going to be 7 slides now. One is going to be nasal resistance. One is going to be soft tissue restrictions, skeletal and dental compensations, the physiologic, the non-anatomic compensations, the behavioral compensations, the genetic contributions, and then the comorbid sleep apnea and UARS. Okay, so this is how this is divided. 7 quick slides, and then we'll be done. So if they have compensations, and this blue color here, these are the compensations. They might have large turbinates, deviated septums, a narrow nasal floor, internal nasal valve collapse, or narrow nares. All right, these are the treatments. These are how we decompensate. So if there's an airway problem, we have compensations, and what we do to solve the problem is decompensate. So the options for decompensation, if you have big turbinates, you reduce the size of the turbinates. All right. And if they're mouth breathing, we use mouth tape, and we tape that so they have to breathe through their nose. Myofunctional therapy is good. Nasal lavage, nasal unblocking exercises, some decongestants, acoustic resonance therapy like the Sonu device, which helps decongest also. So if there's deviated septum, septoplasty. I don't have to go through all of these, but I just want you to start to, get the concept here. So the data shows us, okay, category 1, we have nasal resistance and obstruction. So which one of these things are the compensations most important? And the data points us there. This is where the data leads us. And once we find and identify which one we want to work on, then we go down, here's all the treatments. It's really not that hard. And these things might change. So in this case, soft tissue restrictions are going to be soft palate, tongue size, tongue tie, right? Or weight management. This is all the soft tissue restrictions and that infringe and change the radius of the actual cross section of the airway pipe. Okay. So if it's a soft palatal problem, all right, they might have palatine tonsils or large pharyngeal tonsils or just long hanging palate. So tonsil sonata, TNA. How about a barb repositioning pharyngoplasty? Oral appliance therapy helps with this one too. Tongue size. They can do hypoglossal nerve stimulation, skeletal expansion. This is cryolipolysis. So how about freezing some of the fat cells? It's interesting, but if they lose a little bit of weight, they actually decrease their airway problem tremendously. And there's 3 reasons for that. One of the reasons is the least obvious is they have this abdominal visceral fat, which pushes on the lungs. And if they decrease their lung capacity, decreased lung capacity translates into more collapsibility of the airway. And what we also know is the second one is the fat or muscles, the bodybuilders or the people that are overweight and have fat necks, that will infringe on the airway. And also the base of the tongue, the third one. Not too many people really know this, but if you look at some of the MRIs, there's a tremendous change in the size of the base of the tongue, which is infringing on that airway, and it will affect the radius of the airway cross section. So these are other things, tonsillectomies and frenectomies, and the weight management. Now we have the glucagon like peptides, which are very good for short term, 6 months to a year. People are losing 20% of their body weight. So that's going to be very strong. We're going to see a lot of that. There's bariatric surgery. I've seen this, and breathing reeducation is very good as well. And so that is the soft tissue. Then there's the skeletal. What if they already have craniofacial dysfunction? I should call it craniofacial respiratory dysfunction, and bow to Kevin Boyd, because he doesn't like when I use the word craniofacial without respiratory, and I agree with him, actually. But let's keep this simple. What's the problem here? What happens if you have a skeletal problem? You either have a transverse deficiency, you have dental crowding and malocclusion. Again, this is from our data. You may have a anterior posterior problem with the maxilla and the mandible. You may have a retrognathic mandible, and you may have what's called bimax retrusion, which is both the upper jaw and the lower jaw are back. Now, those are the compensations, and the decompensations are down below. These are our treatments, the decompensations. Are they growers or are they non-growers? And again, just to move things along, I'll make this available. It's coming out in Inside Dentistry and Dental Sleep Practice, so you'll be able to see all of these figures. And if you email me, I will send you a copy of the article as well. So these are all the solutions, and it depends on what the problem is. And how do we know what the problem is? By doing the data collection. And this is the physiologic dysfunction. This is what Nicole talked about tremendously today. Arousal threshold, muscle recruitment, loop gain, which I think are really important for us to be involved with. Unfortunately, just to repeat myself, we don't have access to this data, but it's in the data collection form because I think it's coming soon. Although I promise, I've been saying that for about 7 or 8 years. And then we're going to go to number 5, which is this gets into the myofunctional therapy and the speech and language. So this is the decompensation options: mouth tape and nasal clearing, physical therapy, postural awareness, yoga, breathing reeducation, myofunctional therapy for chest breathing. If they have low tongue posture, you want the tongue up and forward, and that helps open the airway. We have myofunctional therapy, nasal clearing, reducing nasal resistance. And then we have, did you want to say something? No, I wasn't sure. Okay, so
Nope.
then we have muscle function. So what if they have lip incompetence or snoring, or they swallow with a tongue thrust, or reverse swallow? It's got a lot of names, that one. Um, and that's a really interesting topic. Save it for another day. And then there's the overactive perioral muscles. So what do we do for this, the muscle function problem? Orthodontics and myofunctional therapy all the time. How about snoring? There's laser therapy. I'm not a big fan. Barb repositioning pharyngoplasty, oral appliance therapy is good for that. It depends. We're going to want to put some of these things together, add them up, and see where we go. Let's keep moving along here. And the genetic contributions. There's syndromic kids, Down syndrome, and many other problems that these kids have. Then parents or siblings have OSA. So this is a risk factor. If parents or siblings have it, you have more likelihood of having it as well. That's the genetic piece there. You can't say it's not genetic at all. It's epigenetic probably mostly, but there's a genetic component too. And then there's metabolic problems. And again, we had talked about that. The periodic leg movements, maybe iron testing. What are the ferritin levels? And for the syndrome of kids, I just, wrote this proactive, protractive orthodontics and myofunctional therapy. Get them when they're young. Get right on top of this at 3 and 4 years old, because this is when they're growing, and this is when it's going to be the least invasive to come up with some solutions. And then there is the CBCT first. And, this became, unfortunately, I press a button and this is a secondary, it's a feature, it's an animation. All the CBTI things come down here. And so it doesn't show because I had to convert this to a PDF for the presentation. So because of the platform for this presentation. And then there's medications, and the DORAs are the medications as needed. But before we get into any medications with the comorbid insomnia, there's so many things. And look up the military approach for insomnia. It's very, very good. It incorporates everything in the CBTI. So CBTI, cognitive behavioral therapy for insomnia, is very, very effective. It gives there's imagery and there's breathing exercises, and it combines a little bit of sleep hygiene as well. I'm sorry they're not on here, but we can make that available for you. And as always, the most important other things for everybody is weight loss, physical exercise. Don't smoke, because it causes inflammation and it decreases the size of the airway. And alcohol, that's a muscle relaxant. So the muscles become more floppy. And we were talking for a while about muscle recruitment, dilator muscle recruitment. And if you have alcohol, boom, you lose that. And avoidance of sedatives, because they make the muscles weak too, and reduce screen time at bedtime. And that's all she wrote. That's the whole program.
That is funny/weird that you had that presentation. We put it on the end. I didn't know exactly what you were going to present, but it really summarized everything we just went through in our interview part,
Yeah,
right?
you didn't know. You didn't see that. I know.
No, I really did not know. And it's so funny that just put it all together. And those were all things we kind of addressed here and there as we're talking. And now it just put it all together. That was wonderful. That was so great. So comprehensive. Thank you so much for going over all of that. Now, people can access the Lamberg protocol, Lamberg questionnaire on your website. Is that where?
The Lamberg protocol isn't there yet, but this is only like a month old. So this is the first time it's been presented in this format. I presented it for a small study group in Manhattan, and it's in front of 3 publishers now for journals. But you know how that is. The editing process takes longer than writing the article.
That takes a while. So everybody can rewatch this part, take notes, print off. This is really important information, because all of us who are working with dental airway patients, there's going to be all of these factors involved in most cases. It's not just one thing. So we need to be aware and attending to all of these different aspects, whether it's airway, structural, non-structural, the anatomic versus the non-anatomic versus the non-airway related components in our sleep patients, and addressing all of these factors to really help our patients get the best treatment and the most comprehensive resolution of their issues. Because if we're narrow-minded, just thinking along one path, just structural or just airway, then we're missing different aspects of how we can treat our patients. You talked about environmental factors, body position, weight loss, all different components. So that was so comprehensive. Thank you so much for taking the time, for allowing me to ask you all those questions and then putting it together in that presentation at the end. I really appreciate that, Dr. Lamberg.
Thank you. Thank you. I mean, it's great.
People should get your book, because just knowing all of the medical comorbidities is so important and eye-opening for us as practitioners, and also for patients, and other MDs should be aware of all those aspects as well. Because like we said, probably not all GI doctors are screening for sleep airway, not all cardiologists. There's a whole aspect of our health that is being impacted by these issues that I think dentists who are in this airway realm are more aware of these things than some of the MDs, right?
Yeah.
So
afraid so. Yeah.
Afraid so. So really great. Your book, Treat the Cause, Treat the Airway, enlightening. Thank you so much for taking the time to help us at the end of your busy workday. Thank you for this.
Can I just add that I do have a course in Northport coming up in September, on the 18th and 19th of September.
Okay.
And they can get in touch with me. And also, if they need any forms, I'm happy to share that. They can just get in touch with the office. Yeah. I guess you can put contact information up somewhere.
I'll put contact information in the notes and your website. And really, thank you for spending all of this time. It's so appreciated.
You're terrific. Thank you for what you do. I mean, you're getting the word out. It's really great.
That's what we need to do, is just keep spreading this information. And this is really not just for providers and dentists, myofunctional therapists, orthodontists, but also for patients. Patients listen to these podcasts as well, these interviews, and educate themselves to find the best help for themselves and for their children or other family members. So it's really power to the community for helping get this information out. And thank you for taking your time as well.
I wanted to say, don't get hung up on when I say decompensations, like solutions for the problems. Don't get hung up on those boxes, because there's more ways to come at those problems. So this is more to just say, here are the compensations, and here's some of the decompensations. And it's not a point that that's the absolute answer for each compensation, but it's to start thinking like that. Most importantly, not treating the severity, which is the way it's being practiced now.
Okay, that's really enlightening. Yes. Well, thank you again for all of your time. Really appreciate it. And look forward to keep spreading this message. So
you're wonderful. You did a great job on everything, and I love your podcast.
Thank you, Dr. Lamberg. We'll talk soon. Thanks again.
Bye-bye.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info, or check out our site at www.airwayanswers.info. Thank you so much, and join us for the next one.